Hello, my name is Casey Ann Barber, and this is my theory review and application presentation for class HSC 6603. Let's get Now, before we get started, I want you to take a minute and think about if you know the answers to any or all of these questions. How many people die from cancer worldwide? What are the most common cancers that are diagnosed? And what is the role that cancer screening has on reducing the burden of cancer? If you don't know the answer to these questions right now, I hope you will by the end of this presentation. During this presentation, I will review some literature comparing the health belief model and the social cognitive theory on cancer screening, my health behavior of choice. According to the World Health Organization, cancer is the leading cause of death worldwide, accounting for nearly 10 million deaths in 2020. This equals about 1 in 6 people dying from cancer. The most common cancers are breast, lung, prostate, colon, and rectum. It is estimated that about 30 to 50% of cancers can be prevented by avoiding risk factors such as tobacco use, alcohol consumption, unhealthy diet, physical inactivity, and air pollution. It is also understood that the cancer burden can be reduced through screening and early detection of cancer. Cancer screening aims to identify findings suggestive of cancer before individuals have begun to develop symptoms. This is where health educators can have a lot of impact by developing screening programs to target at-risk populations, educating individuals about their cancer risk and the available screening methods, and increasing screening numbers overall. Now let me give some more background on the two theories I chose for this presentation, the health belief model and the social cognitive theory. First, let me start with the health belief model. This is one of the most used theories in health education and promotion. It was developed in the 1950s to explain why people were not participating in programs to prevent and detect disease. It was thus designed to motivate people to take positive action to decrease or avoid negative health consequences. The health belief model can be used to explain health-related behaviors or lack thereof, and as a framework for interventions. Essentially, it is a model that focuses on changes in beliefs that lead to changes in behavior. The health belief model has 6 primary constructs that help determine if and why people will take action to prevent negative health consequences. The first construct is perceived susceptibility. This is a person's belief in their chance of getting a disease or condition. The second construct is perceived severity, which describes a person's belief in the seriousness of a disease and its consequences. Now, I do want to mention that there is a construct called perceived threat that is not a key or primary construct of this model, but it is still used. This construct is a combination of severity and susceptibility. The two constructs are multiplied together to form the perceived threat of the disease or condition. Okay, getting back on track. The third construct is perceived benefits, which describes the positive aspects of the recommended behavior to reduce the risk of the disease or condition. The fourth construct is perceived barriers. These are the possible obstacles and negative outcomes of a recommended behavior or action. The next construct includes cues to action. These are things that trigger the desired health behavior. Cues to action can be both internal and external. The last construct is self-efficacy. This describes the confidence that one has to adopt the desired behavior. Now let me shift gears to describe the social cognitive theory and its construct. Social cognitive theory is an interpersonal theory, meaning it shows relationships between people. The social cognitive theory integrates cognitive processes with observational learning. There is reciprocal determinism between personal cognitive factors, behavioral factors, and social environmental factors when describing human behavior. This theory affirms that to participate in behavior change, individuals must possess the knowledge and skills necessary to perform the behavior and the belief in their capability of performing that behavior in that specific situation, also known as self-efficacy. The personal cognitive constructs include self-efficacy, collective efficacy, outcome expectations, and knowledge. Self-efficacy is the most important construct and is the confidence to engage in a behavior. Collective efficacy is essentially social cohesion, the idea that groups work better together. Outcome expectation is the ability to see the outcome of a behavior. The premise behind this construct is that people will behave in ways because they expect to see specific results. Lastly, knowledge is having information about the behavior and how to perform it. The social environmental factors include observational learning, normative beliefs, social support, and barriers and opportunities. Observational learning is watching someone, typically an influential role model, perform a behavior so you can learn how to do it. Normative beliefs are cultural beliefs, social acceptability, and perceived prevalence of the behavior. Social support includes perceptions of encouragement and support for peers. Barriers and opportunities are environmental aspects that can make it easier or harder to change behavior. Lastly, the behavioral constructs include behavioral skills, intentions, and reinforcement. Behavioral skills are the skills and knowledge that a person already has to perform specific health behaviors. Intentions are the goals that a person has to modify their behavior. It can also indicate their readiness to perform a behavior. Reinforcement includes rewards and punishments for engaging in a behavior. Rewards and reinforcement increase a behavior while punishments decrease a behavior. Now, let's look at some of the literature utilizing these two theories with cancer screening behaviors. The first study that I'm going to be discussing is by Zare et al., The Effects of Health Belief Model-Based Education on Knowledge and Prostate Cancer Screening Behaviors, a randomized controlled trial. This was a non-blinded randomized controlled trial. Participants were enrolled from April to October 2013. Data was collected for this study through face-to-face interviews with researchers and research assistants. 3 questionnaires were used: a demographic questionnaire, the Prostate Cancer Screening Health Belief Model Scale, and the Knowledge Prostate Cancer Screening Questionnaire. The men in the intervention group were given a free referral to a urologist for prostate cancer screening to assess their prostate cancer screening behaviors. The intervention group attended training workshops, which were 2 4-hour sessions for 2 days. There was a lecture, a group discussion, and brainstorming. I just want to note here that these sessions were offered to the control group at the end of the study. The sessions consisted of education about prostate anatomy and physiology, prostate cancer risk factors and treatment, as well as incidence and prevalence rates in Iran. There were discussion groups about perceived severity, as well as discussions about benefits of prostate cancer screening. The demographics of the study population were as follows. The men were all retired from the Shiraz Department of Education in Iran. The men ranged in age from 50 to 70 years old, with the mean age plus standard deviation being 51.8 in the intervention group and 56.8 in the control group. 210 men were enrolled in the study, and the final participant numbers were 93 men in the intervention group and 87 in the control group. The men had no history of prostate cancer or prostatic hyperplasia. The study did not report on marital status, income level, or education level of the participants, just that any differences found in these demographics had no compounding effect on the study. Now, before the intervention, 95.7% of the men in the intervention group had low or intermediate levels of knowledge. After the intervention, 93.5% of the men fell into the intermediate or good levels of knowledge, showing an improvement. There were no significant changes observed in the control group. The mean score of the health belief model component in the intervention group was statistically different compared to that before the intervention. The only difference seen in the control group was for perceived susceptibility. An independent t-test was conducted, and there was a statistically significant difference between the control and the intervention groups with respect to the mean scores of all the health belief model components after the intervention. There was a significant difference in the mean score of knowledge in the intervention group after the intervention compared with before it. There was no significant difference observed in the control group. Lastly, the participation rate of men from the intervention group in screening increased from baseline at both 1 month and 3 months after the intervention. 24% of men after 1 month got screening, about 41% at 3 months compared to only 8% before the intervention. The authors of this study concluded that health education programs designed using the health belief model could positively affect prostate cancer prevention behaviors of retired participants. Since prostate cancer can be treated in its early stages, they recommended that programs be designed using educational theories to increase the knowledge of prostate cancer screening for earlier diagnoses. The next study is by Sardasht et al., Breast Cancer Screening Behaviors Based on the Health Belief Model. This was an analytical cross-sectional study conducted in Mashhad City, Iran. 5 health centers were involved, and each health center was considered one cluster. Thus, there were 5 clusters in total. The data collection tool was a 2-part questionnaire that was administered via face-to-face interview by the researcher. The first part collected demographic data, and the second part had questions based on the health belief model constructs to measure the woman's belief about breast cancer screening. 406 women were studied from 5 health centers in Mashhad City, Iran. The ethnicity of the women was not described. The mean age was about 33 and a half. About 75% of the women were married. 33% of the women had a bachelor's degree or higher level of education. A little over half of the women were housewives, and 38.7% were employed. About 79% of the women reported that their household income was enough, and a little over half of the women had more than 4 members in their household family. More than 90% of the women reported not having a family history of breast cancer. A little over half did not conduct a breast self-examination during the last year. 80% did not receive a doctor's examination in the last year, and 91% reported not getting a mammogram within the past 3 years. The questionnaire revealed the severity of the health belief model constructs related to cancer screening behavior in the study women as follows. A little over 64% of the women ranked high or very high on perceived susceptibility. 61% ranked medium to low on perceived severity. More than 78% ranked low or very low on perceived benefits. 51% ranked very high or high on perceived barriers. 55% ranked low or very low on cues to action, and 75% ranked high to medium on self-efficacy. This showed that the women had a moderate to high susceptibility and perceived severity of breast cancer screening behaviors. They had good self-efficacy but did not understand the benefits of breast cancer screening, and many felt they had barriers to breast cancer screening. Pearson correlation coefficients showed various relationships between the health belief model constructs, but it was found that only self-efficacy and cues to action could predict breast cancer screening behaviors in the study. The authors of this study recommended examining the factors that increase self-efficacy to perform screening behaviors in women of different reproductive ages. They concluded that through educational programs that focus on strengthening self-efficacy of conducting breast cancer screening, more women will adopt this health behavior. This is the last health belief model study that I'm going to discuss. It is by Abesada et al. And is titled The Relationship Between Women's Health Beliefs and Their Participation in Screening Mammography. This was an experimental control group study with 2 groups divided up as follows. The experimental group contained women who had received a mammogram, and the control group contained women who had never had a mammogram. The data collection instrument was a questionnaire. Questionnaires involved demographic data, mammography experience, family history, and a Likert scale measuring health belief model constructs concerning breast cancer screening. Women over 35 years old in the province of Kerman, Iran, were included in this study. There was no description of the number of women included, as well as other demographic data. However, it was noted that this information was collected on the questionnaire. Now, the study found that the experimental group, which were women that had previous history of mammography, scored higher than the control group for perceived sensitivity, perceived severity, and cues to action constructs. There was no significant difference between the groups concerning perceived barriers and self-efficacy. A linear regression model showed that perceived sensitivity scores depended on having a history of benign breast mass and a family history of breast cancer. Cues to action depended on the group, with those who had a history of benign breast mass scoring higher, having a family history scoring less, and increasing age scoring higher. The study authors concluded that women's health beliefs about getting mammograms were different between the group who had received mammograms and those who had not. These differences in attitudes led to one group getting mammograms and another group not participating in this health screening behavior. They concluded that nurses should use the health belief model to evaluate people's beliefs about health threats and health promoting practices to increase participation in programs that improve people's health. Now, this study by Boehm et al. Is the first study I'm going to discuss utilizing the social cognitive theory. It is titled Prostate Cancer in African American Men, Increasing Knowledge and Self-Efficacy. This study used a subsample of subjects from a larger quasi-experimental study of an educational and screening program for prostate cancer from African American churches in a major Midwestern city. The participants attended an educational and screening program presented by an African American urologist and an African American prostate cancer survivor. They also completed pre-test and post-test of the prostate cancer screening knowledge inventory and the prostate cancer screening self-efficacy scale. The knowledge inventory had true-false questions, and the self-efficacy was a Likert scale that measured how well they felt they were capable of performing the behaviors required to screen for and detect prostate cancer. As part of the larger study, the African American men who had been diagnosed with and treated for prostate cancer were trained as lay educators. The educational program consisted of information about prostate anatomy and physiology, prostate cancer detection and treatment, and then the lay educators told their story. The 2 data instruments were administered before and after the education session. 123 African American men were enrolled. The participants ranged in age from 31 to 78 years old with a mean age of about 53 years. More than 78% of the participants were married, 35% of the men had a college or advanced degree, more than half of the men reported a family household income of between $20,000 and $39,000. Key tests revealed a significant improvement in participants' prostate cancer screening knowledge following the church-based educational and screening program. The knowledge scores increased from 8.7, which was the pre-test score, to 10.1 post-test. There was also an increase in the self-efficacy scores after the program. Scores went from a little over 14 to 17. The authors of this study concluded that the programs taught by a physician and lay educators who are African American may provide modeling and reassurance for African American men to maintain prostate cancer screening methods. They recommended future research focus on a control group of African Americans who received traditional forms of health education from predominantly European American physicians and health educators. They recommended randomizing participants to control and experimental groups and collecting more longitudinal data on their return for regular prostate cancer exams and maintenance of high levels of self-efficacy. This study by Hing-Lo et al. Is titled Social Cognitive Mediators of Socio-Demographic Differences in Colorectal Screening Uptake. Data was collected for this study as part of a population-based omnibus survey conducted in Great Britain from January to March 2014. Face-to-face interviews were conducted looking at screening uptake, had the respondents ever been invited to do a stool test for the National Health Service Bowel Cancer Screening Program, social cognitive factors, which is the belief in the usefulness of screening, an injunctive norm measure, which is what other people think one should do with regards to cancer screening, a descriptive norm measure was included, and then perceived barriers. Now, over 1,300 respondents were included in the final sample. There were both men and women aged 58 to 70 years that lived in England. A little over half of the respondents were men, and the mean age was about 65 years old. 65% of the respondents were married. A little over a quarter were in the highest 2 socioeconomic statuses, and only 4% were non-white. 69% of the respondents reported having taken part in screening at least once. Data analysis showed that all 3 social cognitive measures, screening knowledge, social norms, and perceived barriers, were significantly associated with screening uptake. Perceived barriers and social norms were the most strongly associated with uptake, while screening knowledge showed a weaker association. Socioeconomic status differences in screening uptake were mediated by all 3 social cognitive measures, while ethnic differences were mediated via screening knowledge alone. Differences in uptake by marital status were primarily mediated through social norms. Age had a direct positive effect on screening uptake and a smaller indirect effect via social norms. The study authors recommended that more longitudinal studies be used to further study the social cognitive factors that seem to be associated with socioeconomic differences in colorectal screening uptake. They concluded that a range of social cognitive factors were associated with socioeconomic inequalities in screening uptake, while only lack of screening knowledge was associated with ethnic inequalities. Now, the last study I'm going to discuss is Mirzai, Alivia et al., titled Sociocognitive Determinants of Colorectal Cancer Screening Uptake, an application of intervention mapping approach. This was a cross-sectional study conducted in the Kermanshah province of Iran in 2016. Participants were interviewed in their homes via a 3-part questionnaire. Demographic, colorectal cancer, fecal occult blood test, general knowledge information, and socio-cognitive determinant questionnaire were used. 468 participants with a mean age of about 58.5 years were included. 52% of the participants were male, 76% were married. Only 2.6% of the participants had higher education after high school. A little less than 5% reported having knowledge about colorectal cancer, and 3.6% reported a family history of colorectal cancer. Now, sociocognitive variables accounted for about 38% of the variation in outcome measures of the intention to participate in colorectal cancer screening. Perceived self-efficacy, perceived susceptibility, and attitude were the strongest predictors of colorectal cancer screening uptake. Women, participants aged 70 and older, and those with higher levels of education had greater probability of participating in colorectal screening via fecal occult blood test. The authors also noted that physicians had an important role in providing colorectal screening information to study participants. The authors recommended that designing health promotion programs for at-risk groups to increase their self-efficacy about what colorectal cancer screening tests entail may increase their fecal occult blood test uptake. They noted that designing program interventions to modify individuals' belief about the usefulness of fecal occult blood tests to prevent colorectal cancer would likely be effective in increasing colorectal screening uptake. Looking at all the studies I presented here, I learned that both the health belief model and the social cognitive theory can be utilized to better understand individuals' attitudes surrounding cancer screening behaviors, specifically for prostate, breast, and colorectal cancer. Across the studies, individuals' level of self-efficacy was shown to be a common determinant in their history of or willingness to participate in cancer screening behaviors. The 2 studies that included educational sessions as part of their intervention highlighted the role that education about cancer screening can have on increasing reported self-efficacy and knowledge about cancer screening. Given the heterogeneity within cancer, future studies should continue to look at individual cancer types, prostate, breast, lung, CRC, cervical, etc. And I feel that 2 things are needed in future research. 1, more study with an intervention group comparing education sessions focusing on the constructs of either the health belief model or social cognitive theory with the control group that did not receive the education to see how this affects cancer screening rates. And 2, more longitudinal studies that look at cancer screening rates 6 months, 1 year, or longer if possible, after the educational sessions just mentioned. This will help health educators design programs targeting the constructs most important to these patient populations. Most of the studies that I discussed during the presentation were cross-sectional in nature. Thus, we're able to provide evidence on what the study participants reported as factors that affect their cancer screening rates. Having more randomized control trials with an educational intervention will help to increase the data on the effectiveness of education targeting those specific constructs or factors on actually increasing cancer screening rates. Audience segmentation will also be imperative in cancer screening health education programs. Prostate cancer screening is different than breast cancer screening, which is different than cervical cancer screening, and specific programs that target individual cancer sites will be more effective, in my opinion, than general information about cancer screening. So in conclusion, when looking at the health behavior of cancer screening, I would choose the social cognitive theory to help design educational programs and interventions. While the health belief model and social cognitive theory have similar constructs, the social cognitive theory adds another layer with the environmental constructs of observational learning and normative beliefs. Incorporating these constructs into educational programs about cancer screening is more impactful, in my opinion, and has the potential to lead to greater behavior change. Now, how would I do this? Because cancer screening is more often than not initiated at primary care providers' offices, this would be my target for cancer screening health education programs. Electronic medical records are now very adept at alerting providers when patients are due for preventative screening exams, including those for cancer. When patients are completing their registration paperwork, either in the office or beforehand, questionnaires could be included in the registration process that assess patients' self-efficacy, knowledge, skills, and barriers surrounding cancer screening. Questionnaires should be individualized based on the cancer type. If a patient is due for a cancer screening test at the time of their doctor's visit, when the nurse brings them back to the exam room, and while they're waiting for their provider to see them, they could be provided with a smart device like a tablet or iPad to watch a video where their specific provider is discussing the importance of cancer screening and providing information about the specific cancer screening that the patient is due for. They can include information about statistics on how many people participate in cancer screening each year, how many cases are diagnosed, what the procedure entails, and even their own experience with cancer screening if appropriate. Let's say the patient has a male provider and they are due for cervical cancer screening. A female patient, nurse, or other provider could have a video clip talking about their experience with cervical cancer screening. This would touch on the constructs of observational learning, normative beliefs, and knowledge. Based on the patient's questionnaire results, additional interventions could be provided. For example, a referral to a social worker if barriers to screening were identified, or additional short video clips could be uploaded and viewed by the patient while they are waiting for their provider. Then, when they are received by the provider, the visit could be focused on answering more specific questions or discussing the timing of getting patients screened. Given the limited time that providers often have with patients, ideally a certified health education specialist or patient navigator would be a part of the PCP's office and could spend time with patients at the end of their visits, making sure they understand what was ordered and what the procedure entails, where to go, and how long to expect to wait for results. And I want to thank you so much for listening to my presentation, and here are all of my references.